Diabetes mellitus is a group of metabolic diseases defined by chronic hyperglycemia. This state results from specific defects in insulin secretion, insulin action, or a combination of both. The core paradox of the disease is a failure of logistics. The body has abundant energy trapped in the bloodstream, but without a functional transport mechanism, the cells themselves starve. The origin of this regulatory system is the pancreas, which functions as the primary source of endocrine regulation for carbohydrate metabolism. This diagram shows the origin point of insulin production, the beta cells, clustered within the islets of Langerhans. Insulin acts as the trigger for glucose uptake into cells. By facilitating this movement, it simultaneously prevents the excessive breakdown of stored liver glycogen. In type 1 diabetes, an autoimmune response permanently destroys these pancreatic beta cells. This causes an absolute insulin deficiency, halting glucose transport at its source. This absolute deficiency most frequently presents before the age of 30, and without hormonal regulation of metabolism, these patients face a severe risk for subsequent life-threatening ketosis. Type 2 diabetes presents a different mechanical failure. Insulin is actively produced, but cellular receptors develop a heavy resistance to its signal. To move glucose into the cells, the body demands ever-increasing insulin secretion until the beta cells ultimately fail to keep up with the demand. The precursor to this state is prediabetes. Impaired glucose tolerance and rising insulin resistance cause hyperglycemic intervals to gradually increase in both severity and duration. This cellular destruction and interference can also be artificially induced by secondary triggers, including severe endocrinopathies, diseases of the exocrine pancreas, or specific drugs like corticosteroids and thiazides. Whether the system lacks the hormonal signal entirely, or the peripheral tissues fail to respond to it, the zero-point pathophysiology remains constant. Glucose remains trapped in the blood, starving the tissues and triggering a systemic metabolic crisis. The crisis accelerates when blood glucose concentrations hit a critical threshold point. The kidneys can no longer reabsorb the excess glucose, forcing it to spill directly into the urine, a state known as glucosuria. This excreted glucose acts as an osmotic diuretic. It drags surrounding water into the renal system, resulting in polyuria. This massive fluid loss decreases intracellular volume, plunging the system into severe dehydration. The resulting polydipsia, excessive thirst, is the brain's mechanical response to this osmotic depletion. Simultaneously, the lack of intracellular glucose triggers a false starvation signal in the brain. The body responds with polyphagia, inducing a constant, intense hunger. Despite consuming extra calories, the patient experiences profound weight loss. Deprived of glucose, the body cannibalizes itself, breaking down vital fat and protein stores in a desperate attempt to synthesize alternative energy. The collapse of cellular ATP production causes profound, inescapable malaise and fatigue. At the cellular level, the hypersaturated glucose environment actively suppresses the immune response. Leukocyte function is heavily impaired, resulting in recurrent infections and dangerously prolonged wound healing. Confirming this metabolic state in a clinical setting requires precise diagnostic thresholds. This table highlights diagnostic parameters: a fasting plasma glucose at or above 7.0 millimoles per liter, or a random plasma glucose at or above 11.1 millimoles per liter with classic symptoms. An A1C level of 6.5% or higher serves as the definitive long-term marker. These classic diabetic symptoms emerge as direct mechanical consequences of a body flushing out vascular glucose while simultaneously cannibalizing its own tissues to survive cellular starvation. To manage this cascade of failures, nursing care utilizes a 12-point intervention framework. This acts as a matrix of targeted countermeasures deployed against specific metabolic and osmotic threats. The foundational assessment intervention requires monitoring capillary blood glucose every 1 to 2 hours in unstable patients to prevent treatment-induced hypoglycemia. Rigorous baseline vascular and neurological assessments are essential to detect the silent progression of microvascular thickening and resulting tissue hypoxia. This diagram maps the exact nodal points for the neurological screening protocol on the diabetic foot, dictating precisely where to apply the monofilament test. Diminished sensation detected by the monofilament or tuning fork serves as an immediate warning sign for neuropathic ulceration. Neuropathic warning signs like diminished sensation and callus formation on a warm foot contrast with the signs of ischemic ulceration, which presents as cold feet, absent pulses, and pale mottling. Wound and skin management interventions require the patient to conduct daily foot inspections using a mirror and to wash their feet only in lukewarm water with strict temperature pre-testing. Patients must dry carefully between the toes, but strictly avoid applying lotion in that space. Extra moisture combined with high glucose body fluids provides an excellent energy source for rapid bacterial proliferation. Clothing interventions specify wearing cotton or wool socks to allow perspiration to dry, while strictly avoiding tight stockings that interfere with already compromised peripheral circulation. Positioning and walking interventions instruct patients to avoid pressure on bony prominences and to never sit cross-legged, maintaining maximum possible blood flow. Toenails must be cut straight across. Ingrown nails act as immediate, dangerous entry points for pathogens. These strict hygiene and perfusion protocols act as the primary defense. Failing to execute them in a high-glucose, hypoxic environment leads directly to osteomyelitis, gangrene, and surgical amputation. The remaining interventions are designed to artificially restore the zero-point transport mechanism and stabilize systemic blood chemistry. This food pyramid outlines the recommended nutritional regulation. A dietitian establishes a 1,500 to 1,800 calorie balanced diet, locking in specific servings for starches, fruits, vegetables, and meats. Absolute regularity in timing and amount of food is necessary to prevent erratic blood glucose spikes. This label illustrates the essential skill of nutritional tracking. Patients must read food nutritive labels to accurately track their specific carbohydrate loads. Pharmacological interventions address insulin resistance in type 2 diabetes using oral anti-diabetic drugs, or OABs. This diagram maps how OADs attack transport failure across multiple systems, decreasing hepatic glucose output, slowing glucose absorption, or increasing peripheral glucose uptake. Nursing responsibilities include monitoring for gastrointestinal side effects and tracking dangerous interactions like sulfonylureas interfering with radioactive iodine during thyroid testing, illness, or the failure of oral drugs. Environmental interventions are vital due to the high risk of diabetic retinopathy. Clear, well-lit pathways prevent trauma for patients suffering from sudden visual impairment. Sleep and elimination interventions anticipate physical disruption due to nocturia and demand the strict monitoring of fluid intake and output to track the ongoing severity of osmotic diuresis. Pain management requires continuously assessing the patient for local ischemic pain, while rigorously controlling blood glucose to halt further neuropathic deterioration. Patient education interventions focus heavily on teaching precise injection techniques and executing pre-planned sick day management protocols. Patients require strict blood pressure monitoring and counseling on smoking cessation to prevent nicotine-induced vasoconstriction from choking off already damaged blood vessels. Finally, routine maintenance relies on rigorous annual complication screenings, 24-hour urine collection for microalbumin, full visual acuity and fundal exams, and fasting lipid profiles. The diabetic nursing care plan functions as a logically prioritized physiological shield designed to replace a failed transport system and protect the body from the effects of internal starvation.